So everybody go ahead and get your lunches and have a seat. And I want to start our introductions. This is a very special opportunity today for two reasons. One is that it's the Memorial Ripley Lecture. And Herbert Ripley was the chair, the inaugural chair of this department from 1949 to 1969. And he served with dedication and distinction as the first chairman of our department. Dr. Ripley, his qualities of kindness, interest, and concern for others endeared him to the department. Under his leadership, the department grew from the original 3 faculty members and a clinical staff of 13 to its at this time, present size of 140, but now it's more closer to 500, I believe, faculty members and many clinical faculty who are associates. Throughout his tenure, he achieved a reputation for excellence in teaching, service, and research. The lectureship in his name is intended to honor those whose work encompasses broad aspects of psychiatric research. And we've had many leaders in the country in psychiatric research give this talk over the years, and I've enjoyed every time I've ever attended one. And I had the special privilege of inviting today's speaker, who is Yvette Chalene. I like to say that I learned about her work when I was driving to the hospital one day, and I heard it on NPR, and it inspired me. And then I found out more about her work. I read the paper, and I've taught it to the residents and medical students since then. So Yvette Chalene went to Harvard for college, and then completed a master's at Yale, and then and that was in physiology. And then she went to medical school at Boston University and completed a residency at Beth Israel in Boston. This is a very conventional, high-powered professional track so far, but then she did something very interesting. She went to California and was not only faculty at Stanford, but she also became the psychiatric director, the medical director for a large system of mental health, which provided treatment to the entire community. And that is a remarkable achievement. But then at that point, she decided to re-enter academics and went to Washington University, proceeded through the ranks, and developed an area of expertise in neuroimaging, stress, and depression, and has made many, many contributions, which I'm not going to try to list for you today. But I have to say that her landmark work in the structural changes associated with depression, but also untreated depression, have had a huge impact on me, and I think on the field and on the community. In 2013, she moved to the University of Pennsylvania, and she is the McClure Chair and Professor of Psychiatry, Radiology, and Neurology there. And I'm going to ask you to join me in welcoming her to Seattle.
Thank you, John, for that kind introduction. Can you hear me in the back? Am I speaking loudly enough? So
the microphone is not quite working as well as the wall.
So if there comes a point where you can't hear me, just go like, and I'll speak up a little bit. So I'm going to talk to you today about an area that is something we've sort of moved into over the last couple of years, and it really marries understanding brain imaging with understanding practical aspects of treatment and how they affect, oops. Okay. How they affect treatment outcome. So starting a couple years ago under the leadership of Tom Insel, there was a series of sort of pronouncements about the inadequacies of current nosology in psychiatry. Basically, people had been saying for a while that we weren't coming up with a new understanding in the psychiatric literature, and that we weren't coming up with new treatments. And so the question was, why was that, and what should be done about it? And so there were a series of position papers and then also workshops to try and come up with a new system of thinking about psychiatric diagnoses. And this was formalized as the research domain criteria. And basically what Tom and other people like Bruce Cuthbert at NIMH talked about was the fact that if you think about pathophysiology, whether it's symptoms or genes or brain circuits, you can find elements of those dysfunctions across different diagnoses. And furthermore, there's a continuum of deficits between disorders and the general population. So it suggests a dimensional conceptualization. And in what I'm going to talk about today, brain circuits, that would suggest that there's a continuum of deficits in specific circuits that perhaps we could associate with deficits in symptoms. Most prior studies have used seed-based analyses to understand brain regions, and so people look at their favorite regions. So in my case, I might look at hippocampus, or other people might have their favorite region, and it might be, cerebellum, or, whatever brain region they like. And most people also have done that in a specific psychiatric disorder. So people have tended to consider deficits in one disorder, and then another study will look at perhaps a different disorder looking at the same deficit. And it's only been more recently that people have started to use this more transdiagnostic conceptualization. So why pick major depression and PTSD, which is what I'm going to be talking about today, like the continuum of disorders across PTSD and MDD. So they're both very chronic, enduring conditions. They have significant morbidity and mortality that includes social and occupational function and high rates of suicide. They both are very recurrent disorders, and they have phenomenological and neural circuit abnormalities that are fairly similar in some cases, but also, as described, there's some differences. And certainly there are specific behavioral differences. For example, an enhanced startle reflex in PTSD that distinguish the disorders. So that while there are similarities, there are also still ongoing differences that result in them being called different disorders. What people may not realize is that major depression occurs in a huge percentage of the cases of PTSD. Not only major depression, but even higher rates if you look at residual depressive symptoms. And that when you're treating a depressed patient, it isn't uncommon to not recognize that they've had some traumatic exposure and may have ongoing PTSD symptoms. Even when you remove the overlapping symptoms, you still get high rates of comorbidity between PTSD and major depression. And then cognitive problems, especially in PTSD, are linked to illness chronicity and have been shown to be difficult to treat in depression. So that's another reason to think about how can we recognize deficits across these disorders so that we can find better ways to treat. So can we probe across disorders? Are there brain abnormalities in resting state functional connectivity and task activity that we can see in both depression and in PTSD? And are there brain signatures of depression or anxiety symptoms across these disorders? Are there dysfunction in specific neural circuits that we can see across both major depression and PTSD? And then finally, what I'm most interested in is, can we correct these deficits? And if we can correct them, are they corrected in the same brain circuits, or would there be perhaps different mechanisms that would correct them? So I'm going to start with a baseline study that just looks at what we saw in our baseline sample across these disorders. And this data was actually collected while I was in St. Louis at Washington University. And it consists of 105 subjects who were diagnosed according to usual criteria by SCID and the CAPS, and had the usual exclusions for neurological disorders, substance abuse, bipolar, OCD. We did not want to include people who were at high suicide risk or who were being treated with psychotropics. We assessed people on the same day as imaging so that we could really be able to associate the symptoms with the brain changes. And then all subjects were required to have complete imaging and phenotypic data. We had pretty rigorous exclusion criteria for motion artifacts because there have been a number of recent publications showing that if you have movement in your data, you can really get some pretty spurious effects. There was a famous study that had to be withdrawn because it showed deficits that were supposedly related to ADHD, but it turned out that what some of the important deficits reflected was simply the motion in the data rather than the disorder per se. So it's something you have to be pretty careful about. I should also say, to be a little bit more clear, that the PTSD folks were all intimate partner violence survivors, and so it's a specific type of PTSD. This is not the kind of VA PTSD that most people think of when they think of PTSD. This is women with intimate partner violence. Oh, thank you. And so this is the sample. The age is on the younger side, about 32. MADRS for PTSD was 19. For major depression, the mean was 27. Lifetime CAPS was 78 for the PTSD folks. And the depressed, let's see if I can make this work. The depressed and the PTSD folks had about the same severity of anxiety and higher MADRS in the depressed folks. And we'll come back to how they did on the task performance in a bit. So the imaging, for those of you who want to know details of imaging, we used a high resolution MP RAGE sequence. The resolution was an effective resolution of about a cubic millimeter. We also had resting state spin echo scans that we used a population specific registration algorithm, which is called ANTS, or Advanced Neuroimaging Tools. And it's one of the best tools for registering resting state data to structural data, because it really has a high ability to line things up. It's been compared with a number of other tools. We realigned all the functional series, smoothed them with a Gaussian filter, confound regress, that just means removing the motion artifacts, and then bandpass filtered and co-registered to the structural image. And then this I'll tell you a little bit more in the next slide, but we used something called multivariate distance spaced matrix regression, or MDMR, to look at the effects of depression, controlling for the confounds of age, anxiety, and motion. And the beauty of MDMR, and I'll show you in a second, but just to remember this in case you want to think about it for your own studies, is that it can simultaneously regress a number of nuisance variables such as age, education, et cetera, and also take into effect a number of independent variables. So you don't have to look at just one independent variable like depression. You could look simultaneously at a number of other variables that you were interested in, but it would get harder to interpret. But you can, it's a very flexible tool. And then I'll show you in a minute, just a spoiler, since what this resulted in was a region that localized to the amygdala, what we then did was used a multi-atlas label fusion that uses multiple different atlases so that it gives you a more accurate representation of the region that you're looking at, to give us a specific cluster in the region that we were interested in. And so this is what I'm talking about. So here's our fMRI series. Using a boundary-based registration, we register them to each other, and then using this anatomical tool, ANTS, we register them to a template. And then we take the fMRI time series, register them to each other, and then voxel by voxel, what we do is look at the connectivity of that voxel with all the other voxels in the brain. And then using this MDMR, what we can do is calculate a distance, which is like how different is one map from each of the other pairs of connectivity maps. And that then gives us this distance metric, which we can then regress with, for example, depression score, the Montgomery-Åsberg Depression Rating Scale, MADRS. And that will then give us a, voxel by voxel, a series of voxels that are significantly different in controls versus patients. And we can, as I said, we can also use the confounds to regress out the confounds that we don't want to have show up. Since, as I already told you, this ended up finding voxels that were within the amygdala, we then can use each person's own subject-specific amygdala, because they're somewhat different. I mean, person by person, our brains differ. So we use each person's own region for the amygdala, and then find what the map is to look at connectivity of the amygdala with all the other brain voxels. Because what MDMR tells you is what's different, what is significantly different. Okay, so it's the amygdala, but it doesn't tell you what it is that the amygdala is disconnected or overly connected to. So in order to do that, you have to do this second step where we look at the connectivity of amygdala with all the other voxels in the brain. So using this connectome-wide association study to search for what was different, it showed that the amygdala was the locus of altered connectivity. So here you can see it's kind of chunky and blocky looking. It's not the prettiest because, it's voxel by voxel. And then in green here, it shows us the connectivity map using each person's own multi-atlas labeled fusion map in green. So it gives you this nice pretty amygdala region. And then using the prettier region, we can then look at the connectivity of amygdala with the rest of the brain to see what is abnormal about amygdala connectivity. So I was very pleasantly surprised that we came up with such a clear result, like, oh, it's the amygdala. Who would have thought? In your nightmares, you think, oh, it's going to show you the cerebellum, or it's going to, I know. I said that deliberately. But it gave us a nice result. I would have accepted the hippocampus too, or any of a number of other interesting regions, but it showed us the amygdala. And then these are all the regions that were disconnected with the amygdala. In most of these regions, there was a diminished connectivity. In a few regions, there was a hyperconnectivity. So the dorsolateral prefrontal cortex, caudate, frontal gyrus, anterior cingulate, all our favorite regions, they're all showing up here. And then here is the subgenual cingulate and the right inferior temporal cortex. And then by looking at the correlation between the connectivity of amygdala to dorsolateral prefrontal cortex, we can see here this relationship between the connectivity and the MADRS score. And what you can see is that the higher your MADRS, shown here, the lower your connectivity was. So if you were more depressed, you had less connectivity. If you were less depressed, you had more connectivity. And then looking, I showed you there was a region as well in the striatum where there was decreased connectivity, and you can see that striatal connectivity with amygdala was also lower in depression, which makes sense, right? That you'd have less basal ganglia activity in depression. And then we found, the initial relationship we found was that depression had higher connectivity scores with amygdala, but when we regressed out depression from looking at anxiety, that was actually a much stronger relationship. So the strongest relationship was looking at anxiety as a function of increased connectivity. So you can see here, the more anxiety you have, the more connectivity you have between amygdala and anterior cingulate, subgenual cingulate. So just to summarize the baseline data, we got a double dissociation in amygdala connectivity. We got depression severity being correlated with amygdala frontal hypoconnectivity for DLPFC, inferior frontal, and anterior insula. And anxiety severity was associated with an elevated connectivity between the amygdala and the ventromedial prefrontal cortex. So the dissociable patterns of this amygdala disconnectivity appear to be sort of a neurobiological feature across the disorders. It wasn't restricted. When we looked at it separately in PTSD and major depression, the relationships were very similar. And it supports the negative valence construct, which is kind of all the disorders that have increased depression and anxiety and so forth in the RDOC concept. So the second question we wanted to know was, can we look at how treatment response occurs? And is there some kind of fundamental feature of correcting these deficits that would be similar across the disorders, or would it be different? So we looked using both resting state analyses and task-based analyses to see what would happen when we treated people. And we focused on cognitive behavioral therapy because we really want, first of all, for practical reasons, because PTSD folks, as you probably know, don't necessarily do so well with medication, whereas treating them therapeutically oftentimes has a much better outcome. And certainly major depression responds well to CBT, and CBT can be implemented in a way that's very manualized so that it can be done very similarly across different patients and with different therapists. We actually had the same neuropsychologist, highly trained neuropsychologist who's the head of the Center for Trauma Recovery in St. Louis, and either did or supervised all of the treatments. So we had a very uniform treatment across the different subjects. So of people who consented to go into a treatment study, we had 34 who were PTSD and 17 with depression. They all got the same 12 sessions of manualized CBT, but as those of you know who treat people with PTSD, what we used in PTSD was CPT, which is cognitive processing therapy, which adds an exposure component to the CBT techniques. So basically, in addition to using the strategies of helping them to think about not overgeneralizing and not catastrophizing and so forth, they are guided through an exposure piece that is, what was this trauma that happened to you, and thinking through. So there is the exposure piece of thinking through the trauma, but it uses the same CBT techniques to revisit the trauma. Patients received a 3T scan both before and after treatment, and they had resting state fMRI and task-based fMRI. We also had a matched healthy controls who were scanned at week 0 and week 12. So for this first analysis, what I'm going to describe is using resting state analysis and using something that one of our very smart statisticians developed, which is called longitudinal functional principal components analysis. And I'll tell you a little bit about that. So what we did was used this map of Yo et al., which is one of the pretty widely used ways of parcellating the brain into these different networks. And then because of what we had seen with our baseline abnormality kind of focusing on the frontoparietal cortex, we restricted our analysis to looking at what happened in this longitudinal functional principal components analysis with this area here in sort of golden colored, which is the frontal parietal cortex. And what the LFPCA does is it looks for change across time. So it's like a PCA, but it's longitudinal. So you look at the difference between what you see at time 1 and time 2, and then you do a principal components analysis on the difference. And so that's a pretty cool technique because, you know, a lot of times we want to see what changes over time, not just what we see at a single point in time. And what it does is it identifies principal components of the change, or eigenimages, that contribute significantly to longitudinal change in connectivity. And in our case, so we found 4 different principal components that did contribute to the CBT changes. And it was principal component 2, which I'll show you in a second, that differentiated patients and controls. So here's a schematic of what happens. You take the patient groups, which is depressed and PTSD, and healthy controls, and then you look at the difference map for each person, time 1 versus time 2, and map it, and then use principal components to dissect it, essentially, into its 4 principal components here. And, you know, another little technical detail, how do you know it's 4? Well, you look at a scree plot and you look at the inflection, and that tells you that the first 4 are what you want to be looking at. And then for each person, you get their principal scores, and you get the average across patients versus controls. And here you can see principal components 1, 2, 3, and 4. And from this little plot, you can probably see that it's principal component 2 that is different between the 2 groups. And then looking at the frontal parietal cortex in blue, outlined here in blue, and then projecting what the longitudinal functional principal components difference was across patients and controls. It's the area in red. So this shows you that it's this specific piece of the frontal parietal cortex that was significantly different between the groups. So this shows you the scores in healthy controls and in patients for the change across time. And then the reviewers that reviewed this paper said, oh, but did you do a whole brain voxel-wise analysis? And so we said, oh, no, actually we didn't. So their critique was that they wanted to see what a conventional voxel-wise analysis would show. So we did that. And you can see but of course it's much harder to do a whole brain analysis because in a fairly small sample, you might or might not be lucky enough to see with all the corrections that you have to do for doing a whole brain analysis. So here in green is the confirmatory voxel-wise analysis that we did, showing that it lines up with frontal parietal cortex map here in blue, the Yo map. This is in red using our longitudinal functional principal components, and the green is the confirmatory whole brain voxel-wise analysis, showing here the patients in blue before and after treatment, and the controls who didn't change. And then just to break it down so that you could see it by groups, in blue are the depressed, and in green are the PTSD, showing that both groups had a significant increase in the connectivity following cognitive behavioral therapy. So what do we know about prefrontal cortex? Well, we know that it's the area that's involved in exerting cognitive control, that executive control allows information processing and behaviors to vary as the task demands change with a particular task or a particular time. So moment to moment, you can adjust your goals and bring in resources to accomplish the task that you need to accomplish. It operates through regions in the prefrontal cortex that represent and maintain the context for responding and achieving goals. And these in turn then bias the processing in other brain regions so that they can recruit, for instance, premotor areas in order to support task appropriate responding. So we know that cognitive behavioral therapy remediates cognitive dysfunction involved in cognitive control systems, in attention, concentration, and executive function. And it may work by strengthening the connections with brain regions that are involved in cognitive control. And we know that patients with both depression and PTSD have cognitive distortions. So it's possible that these cognitive distortions are what you can correct by using cognitive behavioral therapy. So one of the implications, I think, if you're thinking, okay, they're strengthening these connections and strengthening the task performance, is maybe if you had more practice, that the more practice you had, the more CBT would be effective. And so we're actually directly pursuing that idea in a trial that we've just started, where we're doing a computer augmented cognitive behavioral therapy in which we augment the therapist's time with specific tasks that will be both on the computer at home and also on handheld devices that will remind them to do their homework. So, and what we hope to do is to see that. So we'll actually, it has spyware embedded in it. We'll be able to know how much homework they actually did. And so, then we'll have homework completed versus change in brain activity as a metric, and we can see, does it seem to have some basis? And I think the other thing that's interesting is classic studies have found that when you think about cognitive control, there's really a monitoring function, more sort of a cingulate function, and an implementation function, which is more associated with prefrontal cortex, dorsolateral prefrontal cortex. So what we would hypothesize is that because we found primarily deficits in DLPFC that were corrected with CBT, that it's really the implementation that is the deficit and not so much the monitoring. So if it's an implementation deficit, again, really practicing implementing might be the way to fix it as well as we can. So at this point, we're thinking about our future directions. We're thinking about doing an in-depth probe of the time course of CBT effects. Like I said, is there evidence for a correlation between the circuit changes and the time spent doing CBT? And if we could show that, could we make CBT more accessible? So if we can show that the same mechanisms work for computer augmented CBT and that it is essentially a practice effect, perhaps what we could do then would be to substitute in computer performed CBT for some therapist time. Probably not all therapist time, because you need to train people about what to do. But even if you could dramatically decrease the therapist time, it would make it much less costly and much more widely accessible. So that would be a direction that somebody else can take it. And then generalizability of the findings. Can we use the RDoC criteria to look at brain circuits across a broader set of disorders? So the negative valence construct, also known as anxious misery, which includes depression, anxiety, PTSD, panic, agoraphobia, OCD. We're actually collecting a big set of those people right now. We just got a human connectome grant where we're collecting in those people so that we can do a, now I've really
You connect them.
I unconnected it. So we're a careful, also a functional assessment using a lot of different, assessment instruments to look at depression severity, all kinds of different symptoms. We'll be doing a startle response and a whole slew of 8 hours worth of assessing them in the lab, and then brain imaging as well. So, and this data will be collected and then it'll be stored eventually after it's cleaned and so forth, cleaned and sorted. It'll be stored and made available for public access. It would also be interesting to look at what we think of as comorbid depression, although I would argue that in some of these, it may be actually part of the disorder. So for instance, depression in epilepsy, I would argue, is a phenomenon that is part of certain types of epilepsy, rather than being comorbid. And I would say same thing may be true in diabetes, that what you have is a phenomenon where it becomes part of the disorder because it affects brain circuits in ways that produce depression. So we may be able to look across different disorders that are characterized by having high rates of depression to see if we see these same phenomena. And then finally, it will be interesting, I think, to look across different treatments. So cognitive behavioral therapy, antidepressants, ECT, vagus nerve stimulation, deep brain stimulation, transcranial magnetic stimulation, and see are there commonalities across all these different treatments in how they change brain circuitry. And the literature to date would suggest that actually there are some pretty significant differences as well as some similarities. So I think that's going to be an interesting area to look at. Oops, it's not doing anything. Oh, and then ultimately, it would be my goal to be able to bring somebody in, look at them at baseline and say, oh, you should get deep brain stimulation because you've already got all the hallmarks of somebody who's not going to respond to much of anything else. Or, oh, you should have cognitive behavioral therapy because the kinds of brain circuits that we see will be those that are amenable to treatment with CBT. And so with that, I'm going to stop, acknowledge my wonderful collaborators at Penn, my lab, and then all my previous collaborators at Washington University who helped me get this research going and off the ground when I was at WashU. And finally to NIMH for funding this work. And I'll stop there. Yes.
Hi, fascinating. Thank you. Thanks for going all the way up. I'm wondering about testing the reliability of your measurement. Like, if you gave a single person before CBT a series of fMRIs, is it too expensive to do that, or how do you get around that?
That is a phenomenally expensive thing to do. There is somebody, I'm forgetting his name right now, but there's one person who has scanned himself, I think, hundreds of times and published that data. So at least in a sample of one, that data exists.
There was consistency.
There was some consistency. There was some difference. So
But
no, I mean, right. Your brain, I mean, so sleep, deprivation, I mean, all kinds of things change you. And so it is one of the reasons that within the limits of when we can get on the scanner, we like to try and scan people consistently at the same time. But that's a hard goal to achieve given how hard it is to scan people. I mean, ideally, it would be like when you do a lumbar puncture, you want to do everybody 8 o'clock in the morning so that, you get the same results. And I think with an fMRI, ideally, you would be doing it at the same time, under the same conditions, as best you can. Yes?
Thanks for coming. I was wondering, you mentioned implementation and monitoring as sort of different modalities for different sort of correlations. How would you define those two concepts, and particularly how you can have changes in implementation without monitoring?
So actually, there was a famous study published in Science. It was Cam Carter and Jonathan Cohen. It's a classic study. I would refer you to that to look at how they did their study, but they actually did, as best one can, dissociate those functions. Yes.
Do you think your study constitutes indirect evidence that depression and PTSD are fundamentally the same condition?
No.
Or what differentiates them as different conditions?
Well, so we need to go through the caveats. First of all, this was all women, so we don't know about the generalizability to men. It was only intimate partner violence, so it's not, war-based trauma that may be quite a different disorder. The women that we were studying all had very chronic courses. I mean, they had all had long-standing, repeated assaults and violence inflicted on them. Most of them starting in childhood and continuing on. So I think it's a very specific type of PTSD that we're talking about, and may have more similarities with depression, and certainly had a high rate of depression in those people.
But what in the biological findings differentiate? I understand that the differences. And another question would be, did you make a distinction between chronic and acute depression, folks that have depression and not PTSD? But also, like, what in the biological findings would differentiate these two separate conditions fundamentally?
Okay, so the people with depression had to have acute depression at that time. They had to meet current criteria for depression. And, most of them had had previous episodes. So, yeah, you would certainly say, like with the PTSD, it was a chronic condition. Just thinking about, if you think about the items in the caps, those are the things that would classify them as having PTSD. So they have re-experiencing, they may have nightmares, they may have increased hypervigilance. They had all the things that, you think of as being PTSD.
But the depression patients did not.
The depression patients didn't, no. The depression patients weren't re-experiencing because they didn't have trauma.
So the neurons and the biological findings, but there's something that differentiates the PTSD and depression. That's what I was.
So you mean in the activity and the connectivity? We didn't see much difference there. So that was interesting. Okay, yeah, okay. Yes.
You said what was the treatment course for the CBT and CPT? And was there homework built into that model? I'm assuming there was, it just wasn't monitored or didn't have a way to follow up.
So I didn't catch the last part, but it was 12 weeks of treatment, weekly treatment for 12 weeks. And there was a monitoring, a videotaping, and a fidelity to treatment piece built in. Is that what you were getting at?
The monitoring was of homework. I'm assuming that.
Oh, no. In this.
Didn't have homework assigned, but there wasn't a way to.
No, we didn't. No. So the only thing we did was the therapy, was there fidelity in the kind of treatment that was administered. So videotaping the treater doing the therapy.
Do you think there's any chance that less expensive modalities that might be done in a clinic setting, like not an aiming clinic, but perhaps quantitative EEG might be able to have the resolution to show these kinds of things, or is it so fundamental? What are the fundamental differences that make that unlikely? If that's the case?
Well, I don't really know that much about EEG. I think it certainly doesn't have the spatial resolution, so I think it would be hard to know exactly what part of the brain you were affecting. And I don't know if it has the sensitivity either.
And these are deep enough, where the structure is deep enough in the surface that would be a problem.
Right. Yes.
Yeah, just wondering, in either your first study or second study you talked about, have you tried to look at the sensitivity, specificity of any of your networks or activity to really differentiate people with different disorders or differentiate treatment response? Have you tried doing that, and what is it like?
So that's what I was saying. Like, so for instance, when we did the voxel-wise search in the longitudinal functional principal components analysis, we did a voxel-wise search, and that green dot zeroed in on the frontoparietal network. So it was not finding other regions in other networks. In looking at, we did a whole, our linear mixed effects model looked at a whole brain analysis to find those regions that were affected. And I think I showed.
Sure, no, but on individual patients, we're going to translate this to the clinical population versus.
Oh, you mean, is this specific?
How can we use this to take an individual patient?
We can't.
And I know we can now, and that's no problem, that's science.
Mm-hmm.
But how close are
um, I think, so the problem with looking at this data and trying to think about that question is we have way too small a sample. And I think if we had much bigger samples and we could do some machine learning algorithms and could start to tease apart variables, we might be much closer. There was a study, a very interesting study published by Connor Liston and colleagues where they had 500 and some people, and they found endophenotypes of depression where, I mean, basically it pulled out a sort of anxious depression, a sort of anhedonic depression, and 2 other groups. And then they looked at how well people responded to transcranial magnetic stimulation and found that these endophenotypes did predict who responded, that one group responded much better than the other groups to TMS. I think that's an example of how you can use a much bigger database where you can really do machine vector analyses and look at those kinds of questions. But in a database where we only had 50 subjects who completed treatment and got scanned again, it's a much more challenging thing to do. It kind of gives us the hints of what's important, but doesn't tell us more specifically where to go next.
We have some more time for those who'd like to stay after, but I want to thank Dr. Shalene for her presentation and thank you for your attention. It seems to me that your study wasn't really designed to discriminate against things because there's so much overlap.